You take one ordinary bite and a small lightning bolt goes through your jaw. So you stop chewing, then, for reasons known only to humans and curious monkeys, you bite down again to check whether the pain is still there. It is within seconds. Your tongue has become an investigator. You know which tooth is responsible, you know exactly how angry it feels, and you begin calculating when you can reach a dentist, whether the pharmacy is open, and how much of your week this tiny piece of anatomy is about to ruin. Now move that same pain into the Stone Age. There is no x-ray to reveal a crack, no anesthetic injection, no antibiotic if an infection has reached the surrounding tissue, no soft packaged meal waiting in a refrigerator. There may not even be a clear way to explain why the tooth hurts. Yet prehistoric teeth preserve a remarkable story. They show extreme wear, gum disease, cavities, broken crowns, infections, and teeth lost long before death. A few even show that someone deliberately placed a tool inside a damaged tooth, and some of those people kept chewing afterward. So how did they survive a toothache without dentists? The simple answer is that they endured it. Perhaps they pulled the tooth, rubbed something on the gum, or waited for the pain to stop. All of those things may have happened. None of them is a complete answer. Because toothache is not only pain, it can steal sleep, attention, food, strength, patience, and the ability to work. A problem smaller than a fingertip can begin shutting down an entire person. The real prehistoric solution was not one forgotten miracle cure. It was a system for preventing one damaged tooth from becoming total human failure. A tooth looks like a stone set into the jaw, but it is not a stone. Beneath the hard outer enamel is dentine, a living, sensitive tissue connected to the pulp at the center. The pulp contains nerves and blood vessels. Around the root are bone, ligaments, and gums that can also become diseased. This creates several different paths to the same miserable result. A crown can crack while biting something hard. Years of grinding tough food, or food contaminated with tiny abrasive particles, can wear enamel down until dentine is exposed. Bacteria can turn fermentable carbohydrates into acids that damage the tooth. Gum disease can expose roots and loosen the structures holding teeth in place. Infection can spread around a root and create an abscess. The person experiencing the pain would not need a medical name for any of this. They would know that one side hurt when they chewed, cold water might trigger it, pressure might make it pulse, food might become trapped in one particular gap, a swelling might appear along the jaw, and unlike a cut in skin, lost enamel does not simply grow back. A chipped edge can become smoother through use, and the body can lay down some dentine inside a living tooth. But a missing piece of crown does not rebuild itself overnight. The damaged tool must keep working while it remains damaged. That is the first strange part of toothache. The person has to test the injury every time they eat. Not every worn tooth was painful. Not every cavity reached a nerve. Archaeologists cannot look at every dark hole in an ancient molar and know what its owner felt on a particular morning. Pain leaves no fossil, but the physical roots to pain certainly do. This matters because prehistoric humans are often given two opposite sets of imaginary teeth. In one version, everyone has a perfect natural smile because refined sugar has not been invented. In the other, every adult has a mouthful of black ruins because no one owns a toothbrush. Neither picture works. Stone Age diets were not one diet. A coastal forager eating shellfish and fibrous plants faced different dental pressures from a hunter eating large amounts of meat, a community relying on starchy wild foods, or a later farmer depending heavily on cultivated grain. Some populations had relatively little tooth decay, but low rates of cavities did not protect them from severe wear, broken teeth, inflamed gums, or tooth loss. A diet can be low in cavity-producing carbohydrates and still demand years of forceful chewing. Sand, stone dust, ash, or other grit introduced during food processing can make every meal slightly more abrasive. In other places, even people living before agriculture consumed enough carbohydrate-rich wild foods to develop substantial decay. Farming later changed dental risks in many communities, often by increasing dependence on soft, starchy foods. But agriculture did not press a single button that switched tooth disease on for the entire species. Different foods created different problems. Different mouths carried different microbes. Age accumulated damage, childhood development, accidents, habits, and the way people used their teeth all mattered. And teeth were not always reserved politely for breakfast. In some populations, people used their mouths while processing hides, fibers, cordage, or other materials. Teeth could grip, pull, soften, and stabilize. The exact task varied, and a wear pattern cannot always reveal one certain behavior. Still, a damaged tooth could interfere with more than eating. So the popular image of perfect prehistoric teeth hides the real survival puzzle. They did not need to survive only cavities, they needed to survive a lifetime of dental risk without predictable repair. The first response may have been astonishingly simple. A thin point. Humans have pushed objects between their teeth for a very long time. Repeated toothpicking can leave distinctive grooves on the surfaces between adjacent teeth. Such marks appear in fossils from several periods and populations, including Neanderthals. Sometimes the purpose may have been ordinary cleaning. A shred of meat or plant fiber trapped beside an irritated gum can demand immediate attention with impressive authority. Toothpicking might also have been habitual, related to a non-dental task, or simply satisfying in the way modern people continue poking a sore place after confirming that it is sore. But one Neanderthal from Cova Forada in what is now Spain preserves a more suggestive combination. The upper jaw shows periodontal disease and heavy wear. It also carries grooves consistent with repeatedly drawing a hard, narrow object between particular teeth. Researchers propose that the behavior may have helped reduce discomfort in an inflamed area. That does not give us the missing toothpick. It does not reveal whether it was wood, bone, grass, or another material. It does not prove that a healer examined the mouth and prescribed a treatment, but it captures an important mental step. The pain has a location. The location can be reached, and a tool can change what is happening there. That is already more than passive endurance. Then the archaeological record becomes much more invasive. At Chagirskaya cave in southern Siberia, researchers studied a lower molar from a Neanderthal who lived roughly 59,000 years ago. The tooth had two areas of severe decay. One was associated with marks consistent with toothpicking. The other overlapped a deep, carefully modified cavity. Natural wear can make holes. Damage after burial can alter teeth. So the researchers compared the shape and microscopic marks with experimental work on modern teeth. They found that small pointed stone tools, rotated in particular ways, could reproduce the traces. The conclusion was extraordinary. Someone had apparently entered the diseased tooth deliberately and removed material while the individual was alive. This is currently the earliest reported evidence of an invasive intervention for dental decay. It would have required fine control. The mouth would need to remain open. The tool would need to reach the molar without damaging every surrounding surface. The procedure may have hurt. We do not know whether the patient operated on their own tooth or trusted another person to do it. We also do not know what they called the problem, or whether they understood decay in anything like modern biological terms. They did not need to. They needed to recognize that damaged material inside the tooth was connected to suffering, and that removing some of it might change the situation. One tooth cannot establish a Neanderthal dental profession. It cannot tell us how common the procedure was. It may represent a rare experiment, an individual discovery, or knowledge shared within a small group and then lost. But it destroys the idea that invasive care had to wait for cities, writing, or metal instruments. A later case from northern Italy makes the pattern harder to dismiss as a single accident. A modern human known as Villabruna lived around 14,000 years ago. One molar contained a large cavity with multiple areas of decay. Microscopic marks and experimental reconstruction indicate that a pointed flint tool had been used to scratch and lever inside it while the person was alive. The intervention was not a modern filling. It did not restore the crown to its original shape. It looks more like an attempt to remove or manipulate diseased tissue. Not elegant, not painless, but purposeful. By the Neolithic, a few communities left evidence of still more specialized procedures. At Mehrgarh, in present-day Pakistan, researchers identified molars with deliberately drilled holes. Wear along the modified surfaces indicates that the people lived and chewed after the drilling. Stone drill tips associated with bead production provide a plausible technological connection. A skill used to make precise holes in hard decorative material may have been redirected toward enamel. The traditional story often describes these teeth as roughly 9,000 years old. New radiocarbon work on the Mehrgarh cemetery, however, has proposed a substantially younger chronology for that sequence. The exact relationship between the revised dates and every drilled tooth requires careful treatment. The intervention remains remarkable. Its calendar label is less settled than many popular accounts suggest. Another Neolithic tooth, found in Slovenia and dated to roughly 6,500 years ago, contained beeswax over exposed dentine and part of a vertical crack. If the wax was placed there while the person was alive, it may have reduced sensitivity or protected the damaged surface. But there is a frustrating possibility. The wax may have been applied shortly before or after death, Archaeology has preserved the material without preserving the reason. That uncertainty is not a reason to discard the case, it is a reason to tell it honestly. Together, these teeth show experimentation across immense distances and periods, probing, scraping, drilling, perhaps covering a crack. They do not show one continuous institution called Stone Age dentistry. There was no universal treatment manual traveling from Neanderthal Siberia to Neolithic Slovenia. They show something more basic. Humans could observe a damaged mouth, adapt existing tools, and attempt to change the body rather than merely surrender to it. Still, even a successful intervention did not solve the next meal. Imagine a molar that hurts under pressure. The most direct solution is to chew on the other side. That can work until both sides are worn. Another tooth is missing, or the available food demands more force than the remaining teeth can provide. Then the work has to move out of the mouth. Stone tools could slice meat into smaller pieces before chewing. Pounding could break down underground plant foods. Experimental research using foods and simple Paleolithic processing methods found that slicing meat and pounding plant material reduced chewing effort and improved the size of pieces produced before swallowing. The experiment does not prove that a particular prehistoric family prepared a special meal for someone with toothache, but it demonstrates the mechanical logic. A cutting edge, hammerstone, pounding surface, or fire can perform part of the job otherwise demanded from teeth. Depending on time and place, people could choose softer tissues, crush hard items, soak foods, roast them, or cook them by methods available to that community. Marrow and other energy-rich soft foods would require little grinding once accessed. Tough food could be cut into manageable portions. A person could take smaller bites and chew slowly on the less painful side. These were not perfect solutions. Some foods remain difficult to eat without healthy teeth. Processing takes time and energy. Cooking depends on fuel, equipment, skill, and the food itself. A person with an infected jaw may lose appetite even when food is soft. Yet the principle is powerful. If the mouth cannot process the food before it reaches the mouth. That turns tool making and cooking into a form of indirect dental care. It also creates a social problem. The person in pain may be the least able to perform the extra work now required to feed them. Constant pain drains attention. Lost sleep reduces patience and coordination. Bending, walking, carrying, and striking stone can become harder when every heartbeat seems to have moved into the jaw. If fever or spreading infection develops, the person may be unable to gather food at all. Someone else may have to cut, pound, soak, or cook the portion. Someone else may temporarily carry an additional load. The afflicted person may need to switch tasks, remain closer to camp, or contribute through work that demands less movement and less force. Archaeological teeth cannot show this exchange directly. When a tooth is lost during life, the surrounding bone can remodel as the socket heals. That tells researchers the individual survived the loss for some period. Severe wear and extensive tooth loss can also show that people continued living with reduced chewing equipment. But a healed jaw does not contain a receipt for kindness. Perhaps the person adapted alone. Perhaps local food was naturally soft. Perhaps tools made self-feeding possible. Perhaps relatives shared food because of affection, duty, reciprocity, status, or knowledge the impaired person still possessed. Most likely, different explanations applied in different lives. We should not turn every damaged ancient skeleton into a sentimental story about a perfectly caring community. But neither should we pretend survival happened in a social vacuum. Humans obtain and process food together. They learn techniques from one another. A person unable to chew efficiently may still identify plants, repair tools, watch children, remember routes, prepare fibers, monitor danger, teach skills, or perform dozens of tasks that leave little direct archaeological trace. The strongest hunter in camp could lose a molar and become miserable. The older person missing several teeth could still possess the memory that kept everyone from making a much larger mistake. This is where toothache stops being a story about primitive medicine. It becomes a story about how humans manage local failure. Teeth are an evolutionary bargain. They are hard enough to crush and cut food for decades. They can survive forces that would damage softer tissue immediately, but that durability comes with a brutal limit. Once substantial enamel is lost, the original crown does not return. Teeth carry the record of meals, habits, accidents, disease, and age because they cannot continually erase that history. The same durability that makes teeth useful makes their failures accumulate. Ancient solutions were bargains too. A probe might remove trapped material but irritate the gum. Scraping a cavity might reduce damaged tissue while causing more pain or opening another path for contamination. Pulling a tooth could remove the source of suffering or produce bleeding. trauma, and infection. Softening food protected the mouth but demanded extra labor and sometimes fuel. Nothing guaranteed success. Some people probably declined because they could no longer eat enough. Some infections may have spread into bone, soft tissue, or the bloodstream. Some procedures must have failed. The people who died quickly leave less evidence of adaptation than the people whose bones had time to heal. So the answer is not that prehistoric humans possessed a secret natural remedy superior to modern dentistry. They did not. Modern anesthesia, infection control, imaging, restorative materials, and trained dental care are enormous achievements. A professional who can locate hidden decay and repair it before the jaw becomes a survival experiment is not evidence that modern humans have become weak. It is evidence that accumulated knowledge works. But the principle beneath that knowledge is ancient. Find the location of the failure. Reach it with a tool if possible. Reduce the demands placed upon it. Change the food, change the task, share the cost, keep the person functioning even when the damaged part cannot be made new. Return to that prehistoric meal. The person who stopped chewing still feels the pulse in the jaw. Perhaps a narrow point has cleared the space beside the tooth. Perhaps damaged tissue has been scraped away. Perhaps nothing has touched the tooth because touching it would only make things worse. The pain may remain, but now a piece of food is cut smaller. A hard plant has been pounded. A softer portion reaches the person before the next task begins. They chew carefully on the other side. Later, they may perform different work. They may contribute less for a time. They may need help. None of that means the tooth has been cured. It means the failure has been contained. That is what surviving toothache probably meant in many prehistoric lives. Not a clean victory, not a painless morning, not one treatment shared by every human group. It meant getting enough food despite the mouth, sleeping eventually despite the pulse, remaining useful despite distraction, trying a tool when the risk seemed worth it, living long enough for the jaw to change around a missing tooth. The earliest roots of dentistry may therefore lie in more than drilled enamel or wax inside a crack. They lie in the moment someone recognized that pain had a physical source and tried to reach it. They lie in the decision to process food for a mouth that could no longer do all the work. They lie in the human habit of treating a damaged body part as a problem to manage, rather than treating the person attached to it as already gone. One tooth could control every bite. It did not always control the person's entire future. And that leaves a larger question. If a Stone Age group could adapt when someone could barely chew, what happened when that person's main role demanded strength, speed, and healthy limbs? What happened when a Stone Age hunter could no longer hunt?